as possible. I'm Mary Ellen Zupin from the IUSSP Secretariat. Welcome back for day 3 of this IUSSP member-initiated and organized webinar series on the COVID pandemic and sexual and reproductive health in Africa. Today's webinar is going to address health systems and the Sustainable Development Goals, and we've got a great panel of speakers. Again, I'd like to thank Clifford Odemwegu of the University of Witwatersrand and his colleagues in South Africa for organizing this event, and the sponsors, which include the National Institutes for Humanities and the Social Sciences in South Africa and the Population Geography and Research Group in Nigeria. For those of you who are not familiar with IUSSP, most of you maybe, we invite you to visit our website to learn more about upcoming webinars and events. And if you're not a member, please consider joining so that you'll receive email notices about those events and also help support the union. There are reduced rates for those who are based in low-income countries, and student associate members are free. For those who are joining for the first time, I want to give you a brief explanation of the question and answer, the Q&A. Paul, can you move to the next slide, please? Thank you. Please do not use the chat for questions. Instead, open up the Q&A, which is on the little middle of your screen in the bottom. You were invited to ask a question anytime while the presenters are presenting making their presentations. We ask you to give thumbs up for questions you like, especially if one's similar to your own, so that those questions will go to the top and will be more likely to be answered. If your question is for a specific speaker when you're writing it in, please include his or her name so they'll know to respond to that. Some of them may type in answers while others are speaking. If time permits, the moderator may also allow for oral questions and comments during the Q&A at the end. We've got about 10-15 minutes. If you're interested in speaking during this time, please use the raise your hand feature and wait until close to the time of the Q&A so that we know that you really do want to speak. And if you are called on, please limit your comments to less than 1 minute. After the webinar ends, next slide, we ask you to please fill in the survey to provide us some feedback on today's webinar, letting us know what you like, what you didn't like, and how your connection was. And now I'm going to turn this over to today's moderator, who is Reba Petleli. And there it is, over to Reba. Thank you very much.
Oh. Thank you, Mary Ellen, for giving us those introductory remarks. Good afternoon, everyone, and thank you for joining us for the 3rd day of our 4-part webinar series. The focus of our series is on the COVID-19 pandemic and sexual and reproductive health in Africa. My name is Rabaone Betlele, and I will be moderating the session this afternoon. If you would allow me to run you through the program briefly by introducing our speakers, including our discussants for today. Our theme being, as Mary Ellen had already indicated, health systems and the Sustainable Development Goals. Our first speaker is Dr. Renee Weiner. Dr. Weiner will be presenting on the COVID-19 pandemic, sexual reproductive health, and health systems in Africa. She'll be followed by a presentation from Dr. Yemi Adewoyin, who will be reflecting on COVID-19 and the SDGs in Africa. Dr. Olusesan Makinde will give a presentation on telemedicine and access to SRH services under COVID-19. He will then be followed by Professor Jeff Garnett, who will speak to the COVID-19 pandemic and HIV delivery programs in Africa. Our final presenter, before we do our Q&A, will be our discussant, who is Dr. Sasha Freid-Becker. We look forward really to an informative and interactive discussion. As Mary Ellen had indicated, please make use of our Q&A box to pose your questions and some of the comments. Without wasting any time, Dr. Weiner, kindly proceed with your presentation. Thank you.
Okay. Is the presentation up? Is it showing?
It's up.
Okay, fantastic. Thanks very much, Reba, and thanks for the opportunity to contribute and participate in this very fascinating and important webinar. As has been said, today we're talking about health systems and the SDGs in relation to COVID and SRH. And my presentation really builds on very much from the last 2 days, which have really set the scene, created the context, and zoomed in on key issues such as EUP and gender-based violence. But I'll focus very much on the interface between populations and the health system during this pandemic and how it impacts on SRH. This is the outline of what I'll be sharing, a bit of background, then I'll talk a bit about how health systems have responded in relation to SRH previously, then talk about our current situation, and then I'll share some thoughts about responses before I conclude. The examples I'll give are really going to focus on family planning and maternal health, a bit on abortion, and just to say at the outset, because this is such a really huge topic, I won't be talking at all about gender-based violence or sexual assault, which is critical but has been dealt with in great detail and through the excellent presentation yesterday. Okay, just by way of background, to set the scene, we have the SDGs, and this is going to be elaborated later in this session. But to say that we have these targets for SDG 3, which is for good health and well-being, and at least 4 of the 9 targets really relate directly to the topic of SRH, COVID, and health in Africa, particularly 3.1 and 3.7, which look at decreasing maternal mortality and access to sexual and reproductive health and rights, as well as 3.3, which is trying to end communicable diseases, and 3.8, which talks to universal health coverage. And so we can see that all these are targets that we're working towards pre-COVID and now have become really crucial that we don't have setbacks in these various targets. We also have the Maputo Plan of Action, which operationalizes the African policy framework on sexual and reproductive health and rights, which talks to universal access to SRHR, as well as in Eastern and Southern Africa, in South Africa, the ESA commitment, which is a kind of a leading document, which is really a commitment that was signed by ministers of health and education in 21 countries in the region to pledge SRHR rights and decrease barriers, particularly for youth in the region. And many activities and actions and campaigns are really aimed at achieving the goals of the ESA commitment. So we have quite a lot of policy on the continent related to SRH. I'm not going to go through some of the pre-existing barriers to achieving the targets 3.1 and 3.7, but I will, so I won't go through those in great detail, but just to say that there are several barriers that many will be familiar with in relation to achieving those targets. COVID in Africa, it's clearly a great variation across the continent. This has also been addressed in particularly Monday night's presentations. And many believe that the pandemic hasn't affected Africa as badly as predicted. We know South Africa is the most affected, 6th highest number of cases. Mortality, of course, varies. And then Egypt, Morocco, and then Nigeria. And there are different thoughts as to why this is. We've had early lockdowns in many countries, as was outlined on Monday evening in Zimbabwe, Kenya, and Nigeria were cited, and South Africa as well had a very early lockdown. We have outbreak teams, outbreak response infrastructure, lab facilities, and technology that has been repurposed for COVID. So there are several reasons, a relatively young population. But on the other hand, in many countries, we have very weak health systems, which struggle and are easily overwhelmed by additional caseloads, and particularly for severe illness. There's, in many parts of the continent, there is a particular lack of critical care capacity. We've got comorbidities, I don't need to elaborate there. And so the threat of health systems being overwhelmed is very real. Also to say that COVID risk is greatest in urban areas, and particularly in informal settlements and residents. And there are many of these in many parts of the region. So others have also spoken about the Ebola outbreak in West Africa as an example, because we're right in the pandemic now, the COVID pandemic. So we're looking to examples of how the health system has coped or hasn't coped in relation to SRH. And I think the Ebola outbreak is a really good set of lessons, because it's fairly recent. It was 2014, 2015. Although the mode of transmission is very different, it's also a zoonotic disease. And a paper that was published this year showed that there have been very high rates of non-Ebola deaths, particularly in the 3 countries that were very heavily affected by Ebola, namely Liberia, Sierra Leone, and Guinea. And it's been pointed out that the weak health systems were a very important contributor to the scale of the outbreak in these 3 countries. And the epidemic in turn further weakened the health systems. So there's a growing recognition of the need to really invest in health system strengthening and to build resilience of health systems to prepare for epidemics and to respond to the epidemic we're in now, but also future epidemics which are likely to occur. So what is also interesting is that in Nigeria, the Ebola epidemic was averted at this time. And this is described by several writers as a major African success story, that in fact Nigeria managed to avert the Ebola epidemic. And this was for a number of reasons, and a number of factors contributed to the success, including a very early response, coordination, leadership, communication. And I think it's very important to look at the lessons which are outlined in this book, Epidemics and the Health of African Nations. There's a whole chapter that's dedicated to what were the factors that led to Nigeria's success in averting Ebola, in contrast to other parts of that region. So staying with Ebola in West Africa, several people have published and written and researched the issue of indirect impacts of the Ebola epidemic on healthcare utilization. And there's a very interesting systematic review that was published in 2016 that looked at a whole range of health outcomes, non-Ebola related. And an interesting thing was that consistently across the 3 countries that I've previously mentioned, reproductive and maternal health were particularly badly affected by that outbreak. And this was consistent. And what's been documented through a number of studies through this review is decreases in cesarean section rates, facility-based deliveries, antenatal and postnatal care. Outcome data is a lot more scarce, but there is evidence of increased maternal mortality, which is what one would expect, and some modeling estimates that have been done as well. And the one that's quoted here has been quoted previously this week, of around 3,600 maternal, neonatal, and stillborn deaths in Sierra Leone attributable to that outbreak. Just to say that some of those declines were reversed, seemed to come back to the pre-outbreak levels, but some didn't, some persisted, and I think that is of particular concern. Okay, moving then to our current situation of COVID-19 and where we are at the moment. And of course, different countries are at different stages of the outbreak, or of the epidemic, should I say. Many people have described the impact on the health system in terms of demand-driven impacts and supply-driven impacts. And demand-driven impacts are really about underutilization, populations not using SRH services, either through fear of contracting the illness, lack of transport, especially during strict lockdowns, or lack of income related to the economic impacts. Then the supply-driven impacts are numerous, and varied. The one is that it seems that in some situations, it hasn't been very clear that SRH services are essential services. And there's been, in some instances, ambiguity amongst populations as well as authorities around this. And this has led to lack of access. Services have been closed in some places, for example, workplaces. Sometimes government services, clinics have had to close if there have been cases confirmed for sanitizing. And then there have been reports of NGOs who provide mobile family planning clinics whose funding has been redirected and have had to close as a result. I think numerous, hundreds of such examples. There have been stockouts, and then resources, staff, and financing at facility level and health system level has been reallocated to COVID, away from SRH. And then, of course, health workers have been badly impacted through illness from COVID. So quite a lot of issues there. But what is the evidence? And as has been said throughout this week, is that it's early to produce evidence and to share evidence. That's why we've been looking back at other examples. But in fact, there is some evidence that some of these issues that I've raised are in fact panning out. So the evidence is limited. And most of what I managed to find was from South Africa, I guess partly because I'm based here, but also because of the heavy impact here in South Africa. And there've been a few sources, I've listed some of them here, including media reports, which of course is not strong evidence, but is still very powerful and important. So in South Africa, the first study that I'll share is one that was done by the Gauteng Provincial Health Department with Wits University. And many know, and many will know, that Gauteng is a very, very populous province, small in area, but large in number. And this study really just did a clinical services data analysis for the previous 2 years and 5 weeks following lockdown, and was, I think, a really worthwhile exercise, drawing on routine data health systems. And basically what they found was consistent reductions in family planning for injectable contraception and subdermal implants. So the long-acting reversible contraceptions, which are very important in times of closures. So reductions in those and reductions in IUDs. Interestingly, oral contraceptive uptake didn't change. Termination of pregnancy, certainly a decline, particularly in second trimester terminations. And as you know, this is a service that is available legally in the South African public sector. Then another study that's been done and also recently published, this by the University of Stellenbosch, I believe. They've used two surveys, two sources of data. The CRAM survey, I won't go into the details, but basically that was telephonic interviews with over 7,000 adults, and what's called the MATCH survey, which was with pregnant women. All this data collected in June 2020. And again, this shows that the evidence is emerging that utilization is indeed down. So the national survey of adults, the CRAM survey, showed that 23% of adults could not access their usual contraceptives, condoms, or medication in the previous weeks. And this mostly affected, as one would expect, poorer people, those without medical aid, and those with the lowest education level, so the most vulnerable. Then amongst pregnant mothers, 16%, this is a slightly biased sample, I'll go into it later if there's time, but 16% had not been to antenatal clinic in the preceding 2 months. And of those that were in their third trimester, 44% said they were afraid of getting the virus, so they didn't attend antenatal towards the end of the pregnancy because they feared getting ill. A quarter of moms who were postpartum, had not been to the clinic in 2 months. And this is again a worry, not only for the children and immunization, but also because of family planning is often restarted at 6 weeks postpartum. And again, a large proportion said it was because of fear of contracting the virus. And then ART services, 11% of mothers who were living with HIV had run out of ARTs. 40% had not gone to get their to get their ARTs for fear again, and 21% said they had gone, but the clinic had run out. So stockouts are clearly playing a role here. Then a little bit about some media reports that have, again, confirmed lack of access to contraception, transport, lack of transport. I think this is crucial, and it hasn't been widely documented in the published literature, but certainly in media reports, we know that there have been mortalities for women who have not been able to get to health facilities to deliver, particularly during strict lockdowns where mobility has been highly restricted. Home births we know have increased and facility births have therefore decreased. And just, I'm not sure how much time I have left, Reba, but perhaps I can quickly just run through some suggestions of responses to limit the impact of COVID-19 on SRH. And here I'd like to say that I think some of these responses are about responding during the epidemic, and some are more about building stronger health systems and stronger SRH systems in the long term. So to use it as an opportunity to strengthen systems and to reorganize and rethink health systems for SRH. So health service responses are clearly need to aim at continuity of SRH during COVID to limit disruptions such as due to stockouts, rethinking how one organizes health services, increasing the role of community health workers who form a link between services and communities. Telemedicine has a huge role, and we'll hear more about that later. Allowing youth to feel they can access services. There's a very low utilization of health services by young people, and particularly adolescents, and this needs to be really strengthened. In terms of contraception, I think if one promotes long-acting reversible contraception and multi-month dispensing for oral contraceptives, this will go a long way ensuring coverage and lack of interruption of family planning services. And I think increasingly we need to look at community dispensing for family planning. And learn from the experience of the TB and HIV communities, which are increasingly involved in community dispensing, where people can go and collect their medication without having to go to a clinic. This could really, I think, be helpful for many women. Clearly, I think a lot of the maternal health responses really relate to issues that were pre-COVID and are really about strengthening maternal health systems, and particularly emergency transport for pregnant women. Then from the population side, I think it's really important that we look at strengthening communication, social behavior change communication in particular. We need to address the fears. We've seen that service utilization is very much driven by fear, and need to develop communication that allays fears and really highlights the importance of uninterrupted family planning. Communication channels we know that a lot of communication around a range of issues, but including SRHR, is community activation. And during the pandemic, we've learned of many examples where community-based events, whether it's clubs or peer groups or mass mobilization, have been totally put on hold. So one has to look at alternatives. So mobile phones or a mobile phone interaction is one, such as the Mom Connect platform of the Department of Health in South Africa, but also community radio. People want to go online, but then data is an issue. So I think one has to think quite carefully about how one overcomes the difficulty of communication during the time of the pandemic. And then there are many really great campaigns that are really underway pre-COVID, and I think they become more important during COVID. There's the Let's Talk campaign, which is really addressing early and unintended pregnancy, and that's a current campaign that's become more relevant. There's the My Choice, Our Choice, which has been led by SAFAIDS, which is about relaxing abortion laws. So I think there's a lot that's happening in the region that really has great relevance particularly for this situation of COVID. And then finally, I think we need to look at policies to ensure that SRH, are we done? Okay, so just to look at policies.
Please, can we wrap up in 30 seconds?
Sure, Reba.
Thank you.
So to ensure that it's very clear that sexual and reproductive health services are essential services during lockdowns and restricted movement times in particular, focusing, as I said earlier, on emergency transport. There needs to be communication around that. And then finally, to review existing SRH policies and laws which contribute to poor maternal outcomes. And this could be relaxing of some of the abortion laws. And also there are, in many parts of our region in Eastern Southern Africa, there are laws that restrict adolescents from accessing contraception and SRH services. So I think we have a lot to do to relook at those. Thanks very much. And sorry, I've gone over time.
Thank you very much, Dr. Weiner. Thank you for those interesting findings that you've shared with us. I would ask Dr. Yemi Adeoyin to just come straight into his presentation. Thank you.
Good afternoon, everyone. I hope my screen is shared already. I'll be talking about COVID-19 and the Sustainable Development Goals, more of a reflection. And I will try and do that in very few minutes. This is just a brief outline of what I'll be discussing. Africa, as we know, lags behind on so many of the development indices. And we're trying to play catch up amidst our weak health system, governance issues, and so many other peculiar distractions that the African continent, is bedeviled with. Now coming COVID-19. Before COVID, we were trying to play catch up. Now COVID is here. What has been the impact on the little progress we've made so far? And this is what I'll be discussing this afternoon. Because this webinar focuses mainly on sexual and reproductive health, I will therefore be limiting my discussions to SRH related SDGs. And this in no particular order. SDG 1 on poverty, SDG 3, health and well-being, 4 on quality education, 5 gender equality, 6 clean water and sanitation, as well as sexual and reproductive health, so many other things, including family planning, educational services for prenatal care, safe delivery, prevention of safe abortion and management of the consequences, prevention and treatment of reproductive tract infections and STIs, as well as prevention of harmful practices, such as female genital mutilation and eradication of gender-based violence. Now let's look at SDG 3, for instance, health and well-being. What are the targets that are related to sexual and reproductive health? I've tried to tabulate this. The first target here is to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. Indicators include maternal mortality ratio, proportion of births attended by skilled personnel. Then another target is to end preventable deaths of newborns and children under the age of 5, ensure universal access to sexual and reproductive healthcare services. And here the indicator is met modern contraceptive needs, adolescent birth rate, that's between people aged between 10 and 19, then achieve universal health coverage, and substantially increase health financing and the recruitment, development, training, and retention of the health workforce in developing countries. A particular indicator for this last target is the number of physicians relative to the population served. In other words, health worker density and distribution. For SDG 5 on gender equality, the cognate targets that are related to SRH are eliminate all forms of violence against all women and girls in the public and private sphere.
Yemi?
Dr. Yemi?
Eliminate all harmful practices, such as child, early and forced marriages to sexual and reproductive health. I can hear you.
Dr.
Yes,
Yemi, kindly stop your video. Let's see how it will go when it's just your audio. The network is a bit wobbly on your side, on that side. Please, thank you. You may proceed. Apologies.
Okay, that's fine. Okay, can you hear me now? Is this fine enough?
Yes. Yes.
Okay. So I was on SDG 5 on gender equality, and I said the last target that is related to SRH is to ensure universal access to sexual, reproductive health, and reproductive rights. Then on, next slide, please. Then on SDGs 1, 4, 6, and 10, no poverty, aspects of these SDGs that are cognate to SRH include the socioeconomic status of the population and its implication for sexual and reproductive health rights, including sex commodification, access, and inverse care. Inverse care refers to a situation where the people who need healthcare the most, are the least served, and that is as a consequence of their socioeconomic status. Then on SDG 4, quality education. Gender disparity in access to education and its implication again for SRH matters for the impact of COVID-19 on SRH. SDG 6, clean water and sanitation. Here we're saying that wash facilities in itself, distribution and availability for menstrual hygiene, infant health, and even the act of sex they have implications for the attainment of relevant goals on SDG 6. And of course, SDG 10, talking about reducing inequalities, talks about place inequalities within countries and access to SRH services. Next slide, please. Now, this is here we are with respect to the SDGs. Maternal mortality ratio from 1990 to 2017 has been declining steadily, as you can see from the graph. Neonatal mortality rate for 1,000 live births also has been decreasing, and so also is the adult fertility rate, which speaks to the number of adolescent fertility rate, which speaks to the number of women between the ages of 15 and 19 giving birth per 1,000 women. Next slide, please. Here again, health access steadily increasing from 1990 up to 2017, meaning we are making fair progress in making sure that health is accessible to a larger percentage of the population. The number of physicians per 1,000 population has also been increasing steadily over time. And these are some of the modest achievements that the African continent has recorded prior to the emergence of COVID-19. Now, how far we are able to sustain all of this amid our weak health systems, amid our not so good governance structure in some countries, and other local conditions will now depend again on our resilience and how we are able to adapt to the present circumstances surrounding COVID-19. Next slide, please. No, before, okay, yeah. Yes, next, okay. Now, on sexual violence, I singled out South Africa because of the quality of its data when it comes to sexual violence. Not so many countries have detailed data to report this. In South Africa,
Apologies. Dr. Adewayan? Dr. Adewayan? Apologies about that. Your network is
2015 and
breaking.
2016, cases of sexual violence.
Okay.
Yes, please.
I think we're going to need to move to the next presenter. Apologies about that. It seems like Dr. Adewayan's network is poor. Can we kindly move on to Dr. Olusegun Makinde's presentation, and then we will try and probably give Dr. Yemi 5 minutes at the end just to give us a summary of his presentation and probably the results that he would have liked to share with us. Thank you very much. Dr. Makinde, kindly continue.
Hello, everyone. Thank you, Reba. Good afternoon and good morning, wherever you are. My name is Olusegun Makinde, and I'll be presenting on telemedicine and access to sexual and reproductive health in sub-Saharan Africa during the COVID-19 outbreak. This is just an outline. I'll talk about the COVID-19 realities, the epidemiology of COVID in Africa. Then I'll talk about telemedicine and what I think we need to do. COVID-19 is presenting as a one-in-a-lifetime outbreak with devastating socioeconomic and health consequences in Africa right now. Practically all countries of the world have been affected by the outbreak since it was first reported in 2019. There are currently more than 24 million cases that are up to date, that's cumulatively, and more than 830,000 deaths had been recorded by the 28th of August. In Africa, COVID was first reported in Egypt in February 2020. And since then, it has moved across all countries of the continent. We've had over more than 1.2 million cases have been recorded by 28th of August, and more than 28,000 deaths. And also, that's even not the only thing. We've had more than 45,000 health workers that have been infected. And all of this has consequences on the health system. So far, the distribution of cases, like the earlier presenter, like Rene presented, we have South Africa is the most affected country with over 600,000 cases. That's as of 28th of August. With Egypt also has the second largest number of cases, then Morocco and Nigeria. Those are as per cases. And if you look on the right of the screen, we have like a chart that shows the daily cumulative number of cases. Optimists believe that maybe we are beginning to see a downward trend, but there are also other schools of thought that believe that what we are seeing might just be a temporary thing, and the likelihood of a second wave, cannot be ruled out. So how does COVID-19 affect sexual and reproductive health services? First of all, we have lockdowns and restrictions in movement. There are very devastating stories of women who went into labor, and as a result of a lockdown, they couldn't find appropriate transportation services, that could move them to health centers. As a result of that, it can have an effect on, utilization of health services. And there are actually even reports, which I'm going to share later on, that show that women who could not access health services, there were people who lost their life because of that. Besides the fear, the lockdown, the issues concerning lockdown and access to the health services, there's also the fear of contracting COVID-19 during hospital visits. And because of that fear, it can affect the decision to seek adequate healthcare services. Imagine somebody who had been attending antenatal care services, but suddenly heard about COVID, heard about people that died as a result of the COVID outbreak, and because of that, can decide that whatever it is, I'm not going to use the healthcare services. I'm not going to go to the hospital. I'd rather have my traditional birth attendant come provide me service in my own home. So those particular decisions, behavioral decisions, like my earlier colleague presented, are things that can actually that can result in reduced access. Also, there have been closure of services and redirection of effort. Health facilities have been converted to COVID-19 isolation centers. The way this works, if a facility has been converted into an isolation center, it might, as a result of that, increase the distance somebody has to travel to be able to access services. So because of that, the chances of them of going to the facility to seek care when they need to, be it for childbirth services, be it for family planning services, or any other sexual and reproductive services, can be impacted as a result of this. So this actually shows different publications that have been reported and the kind of effect that have been recorded. The first year talks about African pregnant mothers and babies during COVID-19 pandemic threatened by strained health systems and disruption in services. Top doctors and lawyers condemn shocking treatment of women in childbirth during COVID-19. That particular paper talks about how healthcare workers are also under-resourced with things like garments that they need to wear, things about their facial protection, and the N95 masks that they require, and as a result of that, it causes a new friction. There's already challenge of respect and abuse during deliveries, and because of that, because of COVID-19, it has exacerbated that. Ethiopia's midwife grapple with COVID-19 while ensuring safe delivery. That also talks about what I just described. Then there is this paper by Riley and colleagues, Estimates of the Potential Impact of the COVID-19 Pandemic on Sexual and Reproductive Health in Low and Middle Income Countries. That's a paper published in the International Perspective in Sexual and Reproductive Health, and it gives some statistics I'm going to share subsequently. And these are also briefs from UNFPA that shows that the impact of COVID-19 pandemic on family planning and ending gender-based violence, female genital mutilation, and child marriage, it can be threatened, as a result of the COVID-19 pandemic. The UNFPA and partners recently highlighted that the pandemic threatens the achievement of global commitments to ending female genital mutilation, child marriage, and other forms of gender-based violence, depending on the duration of the lockdown. So consequences of the distortion in services. Already we know that access to healthcare or utilization, access and utilization go hand in hand, is low in sub-Saharan Africa. However, with the consequences of the distortion in services, this gap widens further. Riley and colleagues estimate that if the distortion of the services were to extend for up to 12 months in low and middle income countries due to COVID-19, this will result in an additional 48.5 million women with unmet need for modern contraceptive services. It will result in more than 15 million unintended pregnancies, additional 28,000 maternal deaths across the entire continent, and additional 106,000 newborns experiencing complications. So what exactly can we do to address this gap created by the pandemic? We need to look at bridging that gap, and telemedicine serves as a veritable option, that we can adopt. WHO defines telemedicine as the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers, all in the interest of advancing the health of individuals and their communities. So far, historically, telemedicine has been introduced for about 2 decades across sub-Saharan Africa. However, due to the cost and need for specialized equipment, its use was not very popular when it was first introduced. However, recent advances are turning this around. Currently, we don't need any need for highly specialized equipment anymore. There are studies that have shown how simple mobile devices, have been utilized to facilitate telemedicine delivery. There is a high proliferation of smart mobile phones across Sub-Saharan Africa now. Nigeria, the penetration has gone of mobile phones is currently at almost 70% right now. Then also there's been a remarkable reduction in the cost of internet access. So telemedicine use in sexual and reproductive health services, in the literature, there is a study by Gompertz, R.G. et al., which used telemedicine for termination of pregnancy with mifepristone and misoprostol in settings where there was no access to safe services. So what they were doing in that scenario was they were consulting people who wanted to terminate pregnancies, and they supplied them with these drugs. It was brought to them through the mail, and they consulted with the specialists. The women who needed it consulted, and they were guided on how to use it. In that particular study, a fraction, I think it was just about 5% that had complications, needed additional healthcare services in the facilities. Also, exploring the role of telemedicine in improving access to healthcare services is another study that was used in rural Nepal. The first one was in Europe, and this was in Nepal. So I'm just trying to show that it has been used in other places where what we now need to look at is how we can adopt it in our own environment. However, we have some shortcomings. So what are the potential gains of telemedicine? It eliminates direct contact between the patients and the client and the health workers, and that's good for the patient. It's also good for the health workers. We have a wider network of coverage where health facilities are inaccessible because of lockdowns or conversion to isolation centers. So imagine my neighborhood facility has been converted to a COVID-19 center. But there are other healthcare workers who are providing remote services, probably even from South Africa. I'm based in Nigeria right now, and I can easily consult. I can consult with those kind of people. They can provide me advice on what to do, counsel me on things I can do, and if need be, if I need to have that particular in hospital care, then in that situation, I would have to go there. Not all services can be provided remotely. I know people are going to talk about that. Not all services, but we need to look at what kind of services can we provide, through telemedicine services and explore it. Also, this particular provision of telemedicine services can be psychologically reassuring for those afraid of contracting disease, when they visit the health facility. Also, the cost of access, might not be as high as in-person consultation. Because when you talk about in-person consultation, now we need to think about, okay, each person needs to wear a face mask. The doctor or the health worker needs to wear a full PPE, so those particular costs can be eliminated or reduced when not everybody is coming into healthcare facilities for care. So sexual and reproductive services that can be provided remotely can include STI care. We can consult with people, send detail how to collect samples. There are now mobile laboratories that can go, that work with retrieval of home samples. The sample can be sent to the laboratory, and appropriate service tests conducted on the samples, advising the doctor on the appropriate treatment to be given. So that particular way, there's a reduction in the interaction, a reduction in presenting physically in the health facility. Also medical termination of pregnancy, like I showed earlier, and also for routine ANC care, for low risk pregnancy and for medical follow-up, can actually be provided rather than coming as frequently as you normally do, especially for somebody who has had experience of pregnancy before. You can easily provide that kind of service, remotely, and reduce the number of times, not eliminate it entirely, but reduce the number of times the person has to come in. Also, counseling and consultation services for family planning can also be provided remotely. So what are the challenges to the deployment of telemedicine? There's low literacy levels in rural areas of Africa. The cost of internet access, though this has reduced, it can still be significantly high, than it, but it has reduced than it was 10 to 20 years ago, but it might still prove difficult for some. Also, we have lack of standards. How do we ensure quality of care is maintained by providing remote services? And finally, data privacy. Privacy of data of the person that's being consulted. Are we sure that it's not being hacked? Somebody might be HIV positive, and such information might be leaked through inadequate encrypted services. So, in conclusion, the COVID outbreak has redefined the standards and mechanism of care. We need to wake up to the new reality of our time. Without a vaccine, a new normal shall remain for a long time, and the health system needs to respond accordingly, including implementing appropriate interventions to limit nosocomial transmission of COVID-19, such as using telemedicine. For those that might be interested in finding out additional information, there's this paper which we published earlier in August, the role of telemedicine in addressing access to sexual and reproductive health services in Sub-Saharan Africa during the COVID-19 pandemic. It's published in the African Journal of Reproductive Health, and I will put in a link, in the comment section afterwards, so you can access it and learn more about what I've talked about. Also, there's another publication that shows the estimation by Riley and colleagues based at Guttmacher Institute. This actually provides us some kind of estimate of the impact of COVID-19 on sexual and reproductive health services. So thank you very much for listening.
Thank you very much, Dr. Makinde, for that informative presentation. Telemedicine is certainly going to be part of our new normal, and we hope that the uptake in terms of also the resources towards it will increase. Can I just remind our attendees to make use of our Q&A box? It's literally the one on the far right, after the on your screen at the bottom. Kindly make use of that. Any comments that you want to make during the presenter's presentation, please put your comments there so that our presenters can engage with you during the Q&A. So even if it's not a question, you can just put your comments in the Q&A portion. Can I also then move on to Professor Garnett? He will be giving us a presentation on COVID-19 pandemic and the HIV delivery programs in Africa.
Okay, thank you, Reba.
Thank you.
Can you see my slides?
Yes, we can.
Okay, great, thank you. And thank you for the invitation to give this presentation. What I want to talk about is how COVID-19 is impacting on HIV, both the service delivery and potentially the direct impact of the infection. Are my slides moving? They don't seem to be moving. I may have to try resharing. Just try again, sorry. See if this works any better. I've tried to make it full screen. Hopefully it will go full screen eventually. Okay, good, and they're moving. That's good. So what I wanted to talk about is the impact of COVID-19 on HIV, and I think we need to think in terms of the short-term impacts as the pandemic of COVID spreads, but then also how we're going to mitigate that impact and rebuild after the epidemic. What situation are we going to be in, and how are we going to respond to that? And then I think there are potentially long-term impacts, particularly on the funding for the HIV response. So short-term, we need to think about, is there a direct impact of COVID on those people living with HIV? Then we also need to think, as we've heard, about the health-seeking behaviour as people fear exposure to COVID or worry about sort of the police during lockdowns. We've also got to think about the disruption to the health service and whether clinics are being redistributed, as we heard from Renee's presentation, whether healthcare workers are coming into work because they too fear COVID. And we have to be concerned about the commodities and the supply chain. So we need to have interventions to try and avoid these disruptions. Then in the medium term, the potential social and economic effects of COVID-19 could influence risk behavior and ongoing treatment of HIV. So we've got to worry about that and see who's been lost from treatment and how we re-engage them. Potentially with interruptions of treatment, will be drug resistance developed for HIV, and we need to worry about how we monitor that and what we do about treatment regimens to respond to drug resistance. There are potentially some positives, and we just heard about that from Olusana Sesson talking about telemedicine and how potentially some of the tools that we use in responding to COVID-19 can be used to improve our response to HIV in the medium term. Then there's the long-term impact of COVID-19. Debt levels are increasing across Africa and also in richer countries. And so far, in the last decade, we've been spending globally about $19 billion a year in lower middle income countries on HIV. That's going to need to be sustained because people have HIV for decades and will need services for decades. And so we need to make sure that we're making the case to keep that funding going, both from PEPFAR, the Global Fund, and domestic sources, to keep going with our response to HIV. Hopefully, though, what will come out of the COVID pandemic is strengthened health systems, as we've heard, which will potentially improve HIV services as we improve primary health care. And we've got to look at how the institutions such as WHO and UNAIDS change in response to COVID-19, and then what lessons we learn. Just as we're learning in this session about how we communicate in the time of COVID, maybe we can use these communication methods in the future in our response to HIV. So, direct impact of HIV. There's a research coming out of the Western Cape from the data systems that they have. And this has just been, I believe, accepted for publication in Clinical Infectious Diseases, where they're actually seeing a twofold increase in the hazard rate of mortality in those people infected with HIV. This doesn't seem to be the infection, it seems to be the mortality, the clinical severity of the cases that's driving this. It's happening in those under 50-year-olds, which is an important point. The cofactors, risks for COVID death are mainly age and other comorbidities, but in those under 50, HIV does seem to be an important risk factor. And it doesn't seem to be influenced whether the HIV virus is suppressed or not, and whether people are on treatment. But there are big questions about this. The Western Cape has good treatment for COVID, oxygen supplies. Will this be seen in other locations with less strong health systems? The other issue with it is whether it is directly the HIV or the other uncontrolled for comorbidities such as obesity that are leading to this. But it's an interesting finding that we should be worried about. And it seems to be being backed up by studies coming out of the UK, where again, it's not infection that's being influenced by HIV, but there are worse outcomes in the HIV infected patients in the UK. So something for us to worry about in terms of the direct impact of COVID. Early on in the COVID pandemic, lots of disease areas were worried about the attention being taken away from them and then being neglected. So there was advocacy work to say, yes, COVID's important, but our other diseases are important. And there was a coordinated effort to model the impact of disruptions in treatment, which really focused on interruptions in treatment as the biggest effect of COVID. And these were worst case scenarios with 6-month interruption of treatment for 50% of the population. The difference in numbers that the different modeling groups produced was driven by how quickly CD4 counts fall once treatment's removed. And this is an example of, hopefully, predictions being shown to be wrong because we respond to those predictions. And I'll show you some data in a second about treatment. In terms of other areas, on the left, you can see risks of mortality. Not much except treatment influences that in the short term. But on the right, we have incidence, and that's influenced both by transmissible virus in those people who are no longer virally suppressed, and the ability to use condoms because of condom supplies. So as well as worrying about ARV supplies, we should be worried about things like condom supplies. UNAIDS has started trying to collate evidence. This is recent data supplied by countries. So you have to ask the question, what's the quality of data underlying this? But what it's seeming to show is that there are some slight reductions in treatment in places like, for example, Zimbabwe, but it's not as dramatic as was assumed in those models. So this is good news. The supplies are an issue. This is data from USAID, which are showing that there are lines of supplies of antiretrovirals to countries and other commodities that are being delayed, but it's only by about a month, and the number of delays there are decreasing. What we're finding with ARVs and other commodities is that the manufacture is happening okay. Some of the logistics is difficult in terms of transport, but there are buffer stocks. I think the real problem with the ARV supplies is the last mile delivery to clinics, and worry about clinics in their supplies running out. In terms of testing, we are seeing declines in testing, and if we just look at the left side of this, you see dramatic declines in testing in Zimbabwe, which contrasts to what was seen on the treatment numbers. And this is being translated in a number of places into declines of initiations of HIV. So over time, this could build up, and we're going to have to do something about catching up with our diagnosis and initiation of treatment. One tool that's available is HIV self-test, and that potentially could be used to avoid the risks of COVID in diagnostics for HIV, but it hasn't been scaled up particularly well to date. Some of our prevention interventions, such as circumcision, have been dramatically stopped because they're not perceived as essential. They involve contacts with the healthcare system, and hopefully they will be started up again once things turn back to a bit more normality. Previously, we've done work on understanding why people are disengaged from care. This is work from Zambia, done by CIDES, looking at the causes of the interruption of HIV treatment, and then we've designed interventions to try and make sure people don't interrupt treatment. I think we're going to have to do this work again following the COVID pandemic to understand further why people have been stopped their treatment and re-engage them in the clinic. In HIV, we had some tools that were already being worked on. Differentiated service delivery was about making HIV treatment easier for the patient and the provider. And some of the issues like multi-month prescription, remote pickup of drugs, easy access, simplified patient-provider interactions were part of this differentiated service delivery. And there's been a big effort to use the differentiated service delivery as a framework for making sure people continue their HIV treatment as the COVID pandemic progresses. There is a lot of really good information out there on how to respond to COVID in the HIV field. This is taken from the CHI's website, but you can see guidance from the Global Fund, PEPFAR, the World Health Organization on how to manage the situation. And CHI, for example, have got tools on multimodal dispensing, working on how healthcare workers can respond to the epidemic. So there's some really good resources out there for us to use to respond to the epidemic. So just to conclude, I think that there could be dramatic effects of COVID on HIV, and we want to try and avoid those. The impact of that increased hazard rate really depends on how it translates into other locations. We've modeled worst case scenarios, but so far those aren't coming true, which is great, but testing and treatment initiation seem to be worst affected, along with prevention access, and we need to think about how we reverse those reductions in services. The differential service delivery is that framework that helps us respond, but we're going to need to re-engage people who are lost to treatment, and then we're going to have to really worry about the funding environment with the economic disruption caused by COVID-19. So I'll stop there. Thank you.
Thank you, Prof, for that informative presentation. I would like to invite Dr. Yemi just to come and give us his concluding remarks, the recommendations, or like the main gist of the presentation, as we had missed them a little early on due to the network issue. Can we try Dr. Yemi again? Thank you.
Thank you very much. Can you hear me now?
Yes, we can.
Yes, before the short break in transmission, I was briefly discussing some of the gains we've made, on the Sustainable Development Goals. And that includes the gains on neonatal mortality rates, maternal mortality rate, and even the number of physicians to the population served. Next slide, please. Okay, now with the entrance of COVID-19 into the climate, most of these gains are likely going to be eroded. And here I've just shown the list of the top 10 countries in Africa with their number of cases of COVID-19 as at 16th of August. South Africa has the highest number of cases, while Madagascar also happens to make the top 10. Next slide, please. Now, with the advent of COVID-19, there's going to be a reprioritization of public spending, and that means most of the free and largely International Development Agency funded SRH services are no longer going to be available, and there will be diversion of funds into research and development to combat COVID-19. And that means a whole lot of cuts in the budget to SRH. This will definitely impact access to antenatal care services. It will impact access to contraceptives and to other SRH care services. Again, under COVID-19, there's movement restriction, which will affect physical access to health facilities for services including antenatal care or even abortion services. It also affects quota frequency, which is associated pleasure, and of course, intimate partner violence, because it means more people staying at home, whether you blend, in quotes, whether you want to be with each other, whether you have a choice or whether you do not have a choice. So this has led, to aggravation of the incidence of intimate partner violence. Then again, regarding healthcare services, there will be prioritization of COVID-19 patients with respect to personnel and hospital bed spaces. All this will have impacts on the gains made so far with the Sustainable Development Goals. Next slide, please. So to give an idea of what to expect after COVID-19, here are some headlines from media reports. The first one says, women have died or suffered unsafe births after transport bans in Kenya and 44 other countries. Again, COVID-19 puts Sierra Leone expectant mothers at further risk. Doctors' exodus looms as international flights resume in Nigeria. School closure factor rape. School closures a factor in rape of Ethiopian girls during COVID-19 lockdown. And more than 2,000 girls have been defiled, married off during COVID-19 lockdown in Uganda. And again, South African Police Service received 87,000 gender-based violence calls during the first week of the lockdown. Lastly, after the lockdown, femicide rises in South Africa. All these media reports point to what to expect with the implications for eroding the gains we have made, in achieving the Sustainable Development Goals. These are the brief reflections I've had to share with you. Thank you very much.
Thank you very much, Dr. Adewoyin. We apologize for having to break your presentation like that, but thank you for coming in and giving us those last summaries. Without wasting any time, I'd like to invite our discussant to give us her reflections. Dr. Sasha Freid-Becker.
Good day, everyone. I would just like to personally thank you, Madam Moderator, and also thank and congratulate all the presenters. They've provided us with some very important information that requires us to think just a little bit further about what the pandemic means, what it will mean to health systems and to reaching the Sustainable Development Goals during what has been unprecedented times, especially in sub-Saharan Africa. The COVID-19 pandemic forced individuals, it forced communities, it forced governments, as well as all the interrelated systems and networks into an unprecedented shift. We've seen massive shifts in the way we do things. We've seen massive shifts in the way that we think about things. And this needed to happen quickly given the spread of the disease, but it also had to happen in a context of much uncertainty, given what little information we had to work with. Until now, much of the debate around the globe regarding the COVID-19 pandemic has not simply been around the nature and the spread of the disease, but more importantly, the response that governments have taken to it. The different ways in which countries respond and the belief systems that governments and people have had around the world about the most effective way to manage the pandemic is seen the world over. Often these debates center around the impact that the lockdowns have had on education, on employment, and of course on health and health systems more generally. The lockdown strategies that different countries employed came at a time when there was a sense of urgency, and in sub-Saharan Africa, in a context in which employment, education, and health were already severely constrained. Governments needed to strike a balance between saving lives and protecting livelihoods, the slogan often cited by the President of South Africa, Cyril Ramaphosa. However, now, we need to move beyond this and to find more sustainable measures while still mitigating the impact and the spread of the COVID-19. The responses that worked prior to this may not work after this. We are now 10 months into the global pandemic, and if estimations are correct, the pandemic will be with us for a very long time to come. The thinking now needs to move beyond the immediate and move towards the long term. How do we continue to respond to the pandemic without affecting the lives and the livelihoods, maintaining or even improving the health system in order to ensure the least amount of disruption to already strained services, limiting the spread of COVID-19, as well as the potential deaths, not only of the pandemic itself, but if any regression happens towards the achievements of the SDGs. There have been both unintended consequences while others we knew would happen, but the magnitude of the consequences were not envisioned or planned for. Unfortunately, many, as we have seen from the presentations that we have heard today, have undone much of the progress that we made towards the SDGs to date. And we're not entirely sure whether we are going to be able to catch up or whether this undoing of some of the progress is here to remain. The presentations we have heard today bring up some important points, but also questions on how to move forward. There are a lot of interlinkages between a lot of the key themes that we've seen in the presentations, and as such, there are some key points or some key questions for consideration that I would like to pose to both the presenters, but also to the attendees today, as I would very much like to hear the views of those in different fields with different expertise and different experiences, as well as what people have simply thought about and spoken about generally in the different contexts and about these very important considerations. My first is that Dr. Wiener's and Professor Garnett's presentation in particular, but all the presentations more generally, make me wonder whether we have implicated and speak of the pandemic itself as having impacted on service delivery and the health system so far, but whether we should be not looking more closely at the response that we've had to the pandemic, the different types of lockdown measures that we have put in place in these different countries and what this has led to. Albeit cognizant that such measures were made in a time of urgency and with a little available information at the time, I therefore pose a 3-part or 4-part question or area for discussion. What lessons can we learn from the experience this far for a more sustainable long-term solution to finding a balance between mitigating the effect and curbing the spread of COVID-19 and still ensuring that there is, at the very least, no regression on the achievements towards SRH and Sub-Saharan Africa in particular, and reaching the SDGs more specifically, given that the pandemic will potentially be with us for some time. Given that what we do know and do not know until now, what type of health systems research should we be looking at? What are the most feasible and workable models in a resource-constrained environment? A lot of these recommendations are fantastic. A lot of them have been tried and tested, and even pre-COVID-19, they didn't work. One example that comes to mind about the importance of thinking about this very clearly and looking for feasible and workable models in the COVID-19 world is an example that comes to mind. Dr. Wiener and Dr. McKinley's presentations both pointed out a decrease in contraceptive use in facility-based births, for instance, which could potentially have disastrous effects going forward on maternal and infant mortality, on birth rates, especially amongst adolescents and young adults that would have otherwise chosen to avoid this. Given these potential effects, should we not be thinking about how to move beyond facility-based models in a COVID-19 world, over and above the use of community health workers, and what would this potentially look like? This also gives credence to the idea of the supply-driven and the demand-driven impacts, which I thought was fantastic because it really provides us with an understanding of the different fears that people have and the different limitations and challenges that we have, both at the health facility, but the population at large. Further to this, I would like to know the thoughts of the participants as well as from Dr. McKinder himself. Whilst the telemedicine model provides an alternative to contact-based medicine, and it does seem very attractive on paper, given the restrictions in data and connectivity in many parts of sub-Saharan Africa, especially those rural areas which already have difficulty in accessing facilities, the lower educational and literacy levels by certain subgroups on the continent, issues of privacy and confidentiality relating to the use of cell phones in some countries, and the fact that at least some resources and equipment would need to be laid out before being able to roll out a functioning telemedicine platform. And one needs to remember that this is all in the context of competing resources due to COVID-19 and trying to maintain those already existing programs and systems. Is this a feasible option in the short to medium term in sub-Saharan Africa and for COVID-19? And would this not continue to exacerbate the differences between those who do already have access to healthcare and those in which access remains difficult? Professor Garnett's presentation specifically looked at HIV in the context of the COVID-19 pandemic, certainly relevant in sub-Saharan Africa, and I know in my own home country in South Africa, there was a certain level of apprehension and concern at the beginning of the year as to what the spread and effect of the disease would be in those that were immunocompromised, and specifically those that were HIV positive. However, an important consideration that we failed to take into account, but which Professor Garnett's presentation shows, is the impact that the pandemic and the measures put in place has had on the delivery of both the prevention methods, such as VMMC, as well as the effect and the availability and access to ARVs, which could affect adherence, and in the long term, could affect resistance to certain regimens. Whilst the enablers and the interventions are good and valid ones, as were those suggested in the other presentations, As I mentioned before, these have been tried and tested before without COVID. Some more successful than others, and some, given the context, will be time consuming and be competing with already limited resources where governments at the moment are pressured into looking at the COVID-19 pandemic. As such, given the sense of urgency in ensuring that we do not undo decades of work in the context of HIV, what do we do now and what do we do quickly? Have there been any innovative models found elsewhere that have worked, perhaps in situations or areas which had different co-pandemics that we can draw from? One type of model that comes to mind is, for instance, the role of task shifting that was seen in the VMMC programs when the programs were first came out. Task shifting in immunization of infants and children, and even antenatal care. Of course, there could be other more practical models that could be considered and rolled out far quicker. As a final point, two important considerations, one of which was mentioned, but really do need to be discussed and debated if we are going to look for long-term and sustainable solutions in a post-COVID-19 world. Firstly, the potential effect on gender-based violence, gender inequality in terms of health and health consequences, and the impact that this could have on our female population in Africa, given the multiple physical and mental health consequences related to GBV and gender inequality. What data or information is currently being collected on this, and what are some of the possible considerations and implications in terms of the health system that need to be considered in this regard? A second is the consideration of particularly vulnerable populations that may not necessarily be included in the formal system, and which even prior to the lockdown had challenges with access to health services and sexual and reproductive health. Undocumented migrants, sex workers, and injecting drug users, to name a few. I would be interested to hear the thoughts of the presenters and also our fellow participants on whether in their organizations and research, these vulnerable groups have been considered, and or what would be some of the important things to consider, ensuring that these groups are not forgotten or at least sidelined in our recommendations and our way forward in a COVID-19 world. There's just so much that can be said and discussed and debated around health systems, SRH, and COVID-19. But I do encourage everyone to go out and continue these conversations on other platforms, in other mediums. But I now pose back to Madam Moderator to open the floor to the questions and answers from the attendees, and well as back to the presenters. Thank you very much.
Thank you very much, Dr. Fred Becker. Those were really pressing reflections and questions that you have put towards our presenters as well as our attendees today. I would like to give perhaps our speakers first the opportunity to respond if anyone would like to give some comments regarding some of the questions that you posed, because you had directed some of the questions to our presenters, and then we will get into the Q&A session. And the floor is open to our speakers if anyone would like to reflect on what Dr. Fred has discussed.
I would like to respond to what she directed at me.
Sure.
That would it not exacerbate the gaps already created, by pre-COVID, by providing telemedicine services, if it's going to, and I'm particularly responding to this because there are other participants who have asked those questions in the same direction. Let me, first of all, COVID, the COVID crisis is not directed at any specific set of people, and everybody is exposed, be those that are well-to-do who had exposure to services or access to services prior to the COVID outbreak, and also those that did not have access. So everybody is challenged by this same crisis. So if telemedicine is able to to bridge that gap, I don't think it's going to provide any additional, because everybody is affected by the gaps, so I don't think it's going to provide any additional gaps. However, when we talk about people who have who know how to use devices, we might have challenges of maybe people in rural areas who do not have a good understanding of how to navigate electronic devices. That can be an issue, you know. So that's the most important thing about that. Then somebody also mentioned that would it be logical to relate the downward trend observed in the charts I showed earlier, you know, to continuous shortage of testing, at least across Nigeria? If you know, the chart I showed earlier is a chart across the entire sub-Saharan Africa, so across the entire Africa. So I wouldn't think that only testing in Nigeria would bring it down that significantly. So I think it's much more than that. So only Nigeria, because there are other countries that are doing more tests than Nigeria. You know, we saw South Africa, Ghana, you know, and Egypt. They are doing a lot of tests more than Nigeria. So I wouldn't say that just Nigeria. However, what you mentioned, I've not heard about this, that testing centers are not, they are running out of testing kits. I've not heard about that, but it's a possibility, you know, and I don't know how to address that, you know, in light of the current information we have. Thank you.
Thank you, Dr. Makinde. Prof, I see there's a number of questions regarding funding and also funding priorities from the BMGF in light of the pandemic. Can you give us your reflections on that?
Yes, thanks. Yes, sure. So in answer to Clifford's questions, I don't think we've seen declines in funding from the Global Fund and PEPFAR as of yet. And they've been very good about being flexible in their funding and how it can be used. And the Global Fund has funded some COVID work, but that's been additional resources that they've had from donors. So far the funding's holding up. There's a question mark about domestic resources and how they evolve. I think the foundation itself, I should explain a little bit about how we're working. There's a central response to the COVID where there's been $350 million so far put in, and that's really been focused on developing new technologies, testing, treatment and vaccines for COVID itself. And then the rest of us working on our specific disease areas or other development issues have been told to keep going as we were. I think we're going to do a stock taking when the situation's a bit clearer, but for now we're keeping our old strategies and priorities going. Some trials have had to be halted, but generally we're managing to keep going. I think in HIV specifically, our funding for delivery, we actually fund via the Global Fund for AIDS, TB and malaria. And we, as a foundation, directly provide about 1% of the global resources for the HIV response. So it's a small fraction of those resources. And what we're trying to do is do the learning that we can then share and with strategies for making HIV testing, treatment, prevention better in the first place. And as Sasha asked the question about what models are available, we have been doing experiments of what works, things like the task shifting, community distribution of ARVs. Recent work was a DUART study on mobile vans doing treatment initiation and for HIV, and we want to see those lessons continue. So we're going to, I think in this new situation, we're going to have to continue those. And what we're doing is we're scanning where the gaps are in the information we're getting about COVID and HIV and trying to plug those gaps, working with organizations like SAPRIN in South Africa who are doing telephone surveys of what's happening to people. So we are very aware that we need to learn what works in this new setting, but we need to be quite strategic about how we develop the interventions and spread those interventions. And so that's what we're trying to do. Oh, thank you.
Thank you very much, Prof. Dr. Yemi, you pointed out the huge gaps on GBV in Africa and used the South Africa case study to help us anticipate the possible outcomes in the post-COVID-19 scenario. What lessons can Kenya and other countries learn from South Africa on GBV data capture and case management systems? That was a question posed by Mary Muyonga. Dr. Yemi?
Yes, thank you for that question. Issues of gender-based violence is very dynamic and it's culture specific. When I mean culture specific, there are societies where the abusers themselves are even celebrated for abusing, while the abused are condemned. So in such instances, reporting issues of gender-based violence and how the police community or the law enforcing agencies of those societies capture those records will impact on access and the quality of the data that will be available. So essentially, the South African example typifies a system where adequate records are kept and where rights are clear. So for countries that may want to establish a very sophisticated database of violence, then issues of rights will be clear, issues of abuse will be clear, and the agencies involved, will also be able to will understand what it entails. Not that when an abused reports an incident of abuse, he or she will end up being blamed for making herself vulnerable to abuse. So it's all about the system and the society.
Thank you very much, Dr. Yemi. Dr. Weiner, are there some closing remarks as we wrap up our webinar for today?
Yeah, sure. And I think it's been fascinating. I think in response to what can be done and what needs to be done, it clearly needs to be a multi-pronged approach that tackles barriers to access to family planning, particularly for young people, but for all women, and looking at what are the barriers at kind of the structural level, community levels, health systems, and individual levels. And then, I think we also need to look at how we can combine the resources that are needed for existing epidemics such as TB and HIV and the new infectious diseases that we're seeing, such as COVID. So I did mention community health workers. Is there a role for them to be involved in a range of services and contact tracing and outreach that spans TB in Southern Africa, anyway, TB, HIV, COVID, and SRH. So we need to look at how we can use resources a bit more efficiently. And then, from a public health perspective, I think we're called to strengthen public health at all levels, and in particular surveillance, so that we know that when there are, as we hope, we're at the sort of getting to the tail end in many parts of Africa, but there are likely to be outbreaks and cluster outbreaks, and we need to be able to detect those early and respond early so that the impacts, both direct and indirect health impacts and all the other impacts are minimized.
Thank you very much. As we wrap up for this afternoon, I just want to thank our speakers for availing themselves. Thank you very much for your participation, including our attendees. Thank you for joining us this afternoon. I would like to also acknowledge and thank our webinar organizers, the International Union for the Scientific Study of Population and the Demography and Population Study Program in the University of the Witwatersrand, as well as the National Institute for Humanities and Social Sciences in South Africa and the Population Geography Research Group in the University of Nigeria. So a big thank you to Professor Odimengo and the team for putting together this webinar series. Thank you very much, and we look forward to seeing you again tomorrow at the same time, where we will be looking at the methodological, demographic, and funding issues. Thank you, everyone. Have a good evening.